This is ASAP Pathway. Hi, friends. Welcome back to another episode of ASAP Pathway, the podcast. I'm your host today, Dr. Stacy, joined by my partner, Dr. Michelle today. Hello, Michelle.
Hello, Stacy. Hi, Angie.
And then I was
Hello.
gonna, yeah, and Angie's here too. And you went ahead and introduced my guest. I was gonna say you're at the ADA, so you're for the listeners today. If it sounds like Michelle might be in a tin can at times, it's because she snuck off to a room at the American Dental Association. Currently, she's there with ASAP. They have the
Yeah,
Pediatric Airway Symposium today. So that's where she is today. So welcome and thanks for stepping away to have this much needed conversation today. And I'm going to introduce our guest today. She is a return guest because she's so amazing. This is Dr. Angie Tenholder joining us today. I'm honored to call her my friend as well. Matter of fact, we just got together at your place last week, and it's like a retreat going to her house. I love it. She's like, I'll come to your place. I'm like, nope, I'm coming to yours. I love her house. For those of you that want to catch up, part three, episode 3 was when she was on, and I did her bio there, and I really want to jump in. We got some juicy stuff today. So most of her bio I already read in episode 3. Please check it out. That's my way of getting you to go back and listen to what she had to say there. Today, we're going to continue with some really interesting stuff that she's a part of, and some opportunities for you, the listener, whether you're a provider, a healthcare provider, or the everyday person listening. There's a place for you at this table, and Dr. Angie is inviting you to the table. So we'll give you some information on how you can be present, how you can get plugged in and learn more to take care of those you love. Without further ado, I'm going to jump in. Dr. Angie not only has all these other accolades in her background, but she is also an extensive, diversified dentist. She serves as the president of the American Board of Craniofacial Dental Sleep Medicine, the ABC DSM, and is board certified with a diplomate status in that organization. She's completing her final term as a director and served as the former Education Committee chairperson for the American Academy of Craniofacial Pain, where she also holds fellowship status. In addition, she has achieved fellowship status in the Academy of General Dentistry and maintains AGD PACE approval to deliver continuing education courses through the Synergy Academy. She is the creator of Baby Lays and a seasoned educator and course instructor, leading live and online training in techniques utilizing neurodevelopmental dentistry, say that 3 times fast, to include ALF therapy, Baby Lays, Oral Lays, and Restore Lays. She's been featured at national and international events, including courses, webinars, and conferences. Welcome, Angie. Thank you for coming back.
Thank you for having me again.
I wanted to dive in a little bit in the bio. You have the AADSM, and it has its board, and dentists can become board certified or diplomate status in dental sleep medicine with that academy. There's another academy, the ABC DSM. What's a little different about the ABC DSM for people that might be looking for a dentist that has a diplomate status in one versus the other? What makes the board you're on unique?
So I'm not an expert at what the AADSM offers, but I am happy to share with you that the ABC DSM has gone through a rebirth. We are opening our hearts, opening our doors and our minds to people who want to learn more about pediatric airway and make that part of our certification process. Also about all the other things about sleep medicine that may or may not be handled with a dental sleep appliance, such as like night lays and assisted pallioplasty and those kinds of things that also improve patient quality of life through understanding deeper sleep physiology from a neurological component. And it's always amazing to see how great people are doing with the things they already know, but they might be missing one thing, like gut biome or neural circuits. And then we say, well, what if you can add that on top of it? And how much more effective could it be with your treatments? You're already doing good. Now you can do great. And that's what we're offering through our organization is to be able to bring credentialing status, also virtual credentialing status. We're rewriting the exam with the most recent literature involving all the things. And rest in peace, Dr. John Rimmers, for
Mm.
his gift of saying that AHI is not really a factor that should be primarily considered anymore, that it's just not effective. And then I believe his quote says that not many since 2000 take into account all of the neurological things that need to be considered. And that's our goal with the ABC DSM is to bring that forward so people don't have to be intimidated by it because it can be super intimidating to think, oh my gosh, neurology, wasn't that a class that I took a million years ago? We're just applying it in real world applications and showing you how to use it on a daily basis. And that's what our conference is doing this November as well, which we're super excited about.
Well, and I am super excited about it too. I am going to be speaking on a couple of the days with you. I mean, I'm just honored. I'm always I feel like such imposter syndrome when I'm around Angie because she is brilliant, and she's like, "Would you like to speak or would you like to say something?" I'm like, okay. I I hope I deliver, but I'm really excited. Well, I mean, we're talking about the conference, so let's just jump into the conference a little bit. At least touch on, it's November 21st, November 22nd. The 21st is the 3I course
The 20th
symposium.
is 20th is the 3I. So
The
the day
20th is the 3I.
before,
Okay.
yeah. So Thursday before, we're doing an actual course where we're teaching people how to do the hands-on component of assessing these invisible influencers. So 3I's identifying invisible influencers. And some of those include Stacy's topics where she talks about, serum biomarkers and gut health and all the things that you are so amazing and brilliant at discussing. But then we also have Christy Gatto, who is going to be bringing forth a new spin on oral facial myofunctional therapy with the neurological approach and how important that is because the swallow is neuroreflexive. We cannot habituate a patient into an effective swallow. We have to convert. So the neurological part of it is the actual conversion. So she's going to be discussing that and talking about assessments. And then I'm going to be talking about the neural circuits of the trigeminal region and how we have to understand the operating system of our body and our brain to be able to use our therapies as dentists and dental sleep medicine providers to their optimal use and highest use, which is what I'm so excited to bring. And then Friday and Saturday, we have different speakers. Stacy's one of them. Christy's another one. Our keynote speaker is Dr. Gabor Mate, who is a world-renowned, internationally recognized author, New York Times best-selling author, with the topic of when the body says no, basically talking about the role of adverse childhood events and early childhood trauma and how it shapes an entire lifetime. And he will be the first to say that this is complicated, but when you have an adverse childhood event before the age of 3, it can create addiction, it can cause cancer. I mean, it's a direct relationship. So his lifetime journey is to bring awareness for that. And then we have you guys through ASAP pathway because kids can't wait. And that's what he's talking about is that you got to treat them young. You got to address this and you got to overcome those because the brain does not know the difference at all between emotional and physical stress. So trauma of any kind will derail that brain. And then we have, as dentists, an amazing opportunity to harness the power of the brain and the body to help patients overcome that trauma. So grateful that you guys are bringing awareness to pediatric airway because it's so important. And thank you, Michelle, for being there again at the ADA this year so you can get everyone on the same page with appreciating the value of pediatric care.
Yeah, we really appreciate the ADA for putting this together, right? Because there's not one body that really has supported pediatric airway support and craniofacial development as much as the ADA has. And for them to put together a symposium every year just means that they're helping spread the word. They're helping train dentists. I have dentists. So this symposium, I think, started in 2018, and we have dentists here that are hearing this for the first time. And so we understand that we're reaching more and more people. And so this is really so important in ASAP pathways. So happy just to be able to support the mission of the ADA in helping kids breathe better. But you said something about Dr. John Rummers, and in one of the meetings that I was in, Dr. John Rummers said AHI right now, it doesn't really predict the outcome, right? What you were saying, there's so many other factors that can affect the patient, but what AHI is able to predict is insurance coverage.
Right.
And so it really doesn't say much to the patient's well-being, health, outcomes. It says a lot about, insurance. So this conversation that we're having, and that's why I'm here, because, I really had to make time, and I really had to step away from the meeting because this topic is so amazing to me, because as a provider, you see the limitation of the things that we are armed to do in a general perspective, like oral appliances or even expanders. We know that if you do it enough times and you do it to enough patient population, you will see those patients that there's more, and that's where I was, right? That's what I was searching for before. There's more. I know there's more. I just don't know what to look for. What can I do as a dentist? What else is there? Because I know that the airway is open. What else is there?
Now, this is why we're having this discussion with Angie. And I feel like finally people are more open to the neural component. But it's like anything in medicine, you present an idea and it's totally poo-pooed. It's considered heresy. It's considered there's no evidence for that. Beyond, let's just say we're all anecdotally seeing this and someone starts bringing the attention to the existing paradigm and status quo. There's always this attack and pushback real hard, as we should always challenge something. I'm not saying, oh, here's something new, let's all do it. So there's this balance between challenging and just not listening whatsoever. And sometimes that just happens in the beginning. And so the focus in airway health has been for decades, anatomy, 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 anatomy. There's always been some outliers, always over the years. Brendan Stack, you've got a lot of guys over the years saying, we got to look at neuro, we got to be testing the reflexes, we've got to be looking at what controls the airway. Again, they're the outliers. They're the ones with the arrows in their back. And I think as we are all in this arena over time, like Brene Brown says, I don't want to hear from you unless you've had your butt kicked in the arena. And I think a lot of people have been really working, and we are helping, and the anatomy does matter. And when you need to do rescue breathing on someone, you just got to open the tube. Okay, we got to open this tube. They got to breathe. The kid might need a CPAP. The kid might need a herpes. They need a myofunctional device at night. But what is the long-term goal? And are we addressing everything? And I think finally we're starting to see more people, hey, I've done the expansion. It's helped. Or I've done the tonsils and adenoids. It's helped. We've done the myofunctional therapy. It's helped. But we're still not maybe fully online. And I love how Angie's like, okay, you've done everything. Maybe we need to look at the operating system of the human that you're trying to help. Maybe there's something offline and we just need to plug it back in and get it back online. And that's where I love the term neurodevelopmental dentistry that Angie so amazingly presents. And I really do feel it's the missing piece of the puzzle. And we have been talking about gut health, neurotransmitters, the importance of inflammation, all these things, diet. That's finally emerging. And what's really cool is, we've been talking about gut health. You're seeing so much about gut health and certain species of bacteria in the gut, influencing sleep, influencing oxygenation just by changing the species of the gut. I mean, that's amazing that we're having these discussions. But what's really cool is we're starting to talk about the oral microbiome. That's starting to happen too. And dentists, I think, in the next 5-10 years are just, we've been so integral to overall health, but we're going to see this really important connection, I believe, because what we're doing in the mouth matters. The mouthwashes we're using or not using affects the oral microbiome. There are articles coming out that the oral microbiome affects melatonin production. So, I mean, this is where I love where Angie's coming from, is she's providing a platform, through the ABC DSM, a platform where we can have more of these open discussions and looking at things that maybe we haven't been looking at for a while. So we've got the courses coming up in the fall. I'll put the links to that. And, Angie so graciously said if you're an ASAP member, she would offer a discount as well. So I'll have all that information in there. But what is it, Angie? I know something you get all the time. And I think, and maybe Michelle, I punt this to you because as my microphone completely collapsed and fell in my lap right before we started recording, you two started having a very dynamic. I mean, I was trying to listen, and then Judah, my son, who is my IT guy now, all of a sudden, I was overhearing a discussion that you guys were having just about that topic. And I thought maybe you guys can continue that a little. I'm like, stop, this is the podcast. Quit talking. This is really good. So if you guys can maybe pick up where you were talking before earlier.
I think we can start with what is, you put this term out, neurodevelopmental dentistry. What is that? What does that mean?
So the brain is shaped with movement. In utero, during birth, after birth. Those development of the neural circuits of the swallow and then eventually occlusion is what we all, go to school to learn about the pretty white things. They directly influence every aspect of our existence. And what's so cool is that the Androsanis came out in 2023. We're like, whoa, you know what actually keeps us from not breathing at nighttime? Having functional neural circuits. However, if there is a dysfunctional neural circuit, that is the direct causal relationship of sleep apnea. The only thing that causes us to quit breathing, yes, there can be a comorbid collapsibility structurally as well. But the only thing that will collapse the airway is neurotransmitter depletion secondary to rhythmic masticatory muscle activity and big clenches at nighttime to be able to completely deplete the glutamate stores. And that prevents our ascending reticular activating system from telling us to breathe. So that's an apnea.
Can I just stop right there? We have a lot of people that will use because we know that bruxism is a comorbidity of obstructive sleep apnea, sleep-related breathing disorders. We see it in children and adults. And what you'll hear people say all the time, you're clenching to open your airway. And that's not the case. So can you just back up? See, this is what I'm talking about. When you're around Angie Tenholder and the neuro starts coming out, I'm like, repeat that again, but slower for me, please.
100%.
So go back. Why do we have this rhythmic masticatory action that we're calling clenching or bruxism? Why is this happening in with the research you're coming across and your understanding? What's the purpose of the clenching? It's not to keep the airway patent. What is it?
It's almost like turning over your car. You're like, vroom, vroom, vroom. You're trying to keep awakeness. You're trying to source those neurotransmitters through the mesencephalic trigeminal nucleus, which is located with the highest receptor density in the premaxilla, the muscles of mastication, and the apical third of the teeth in the PDL. So when you're sourcing input afferents, the in network through the mesencephalic trigeminal nucleus, it creates these rhythmic signals to be able to say, we're going to, and it's about 60% of the population that will do this. We'll keep alertness. It'll keep us from putting breathing. But then when we use up all the glutamate, because of us using this tool improperly, then we collapse. So I use the analogy, if I come home at the end of the day, I'm a little stressed out, I want a little glass of wine. Like, okay, I feel better. 5 bottles of wine will have a different outcome. So you're just doing it too much. And then this patient population will cause the airway to collapse. And the Andersoni studies basically show that the teeth pretty much control the brain in a lot of different ways. And I went to dental school because I didn't want the responsibility of medicine. I just wanted to, go work on a patient, send him home. I'm never going to tell someone, by the way, your child is going to die of leukemia and I can't do anything to save him. But now dentistry has always been in the hot seat because as we are watching these children grow and helping them develop functional neural circuits through the mesencephalic trigeminal nucleus, because we all know there's a motor and a sensory component of the trigeminal, but this mesencephalic pathway goes to the locus coeruleus and the ascending reticular activating system, which all sounds like big old words, kind of like in the movie Waterboy when she's talking about the medulla oblongata and everyone. But honestly, when I roll through this research, I'm like, dang it, it's been in our control the entire time. But there is patient variability in phenotypes, which is why everyone's like, show me your research. Well, the research is going to be based on that person's presentation and an entire lifetime of development and how trauma might offline those systems. Because back to the trauma and why we have Gabor Mate coming. So when you have someone who had early childhood trauma, it creates excessive amounts of cortisol, which prevents these healthy pathways from developing. So the incessant cortisol exposure prevents these projections from the prefrontal cortex into the amygdala, into the hippocampus, into all these areas that are supposed to support us and help us be functional. And some of us don't have that gift of an ideal developmental pathway, which is why sometimes a therapeutic intervention like a tonsillectomy or RPE or whatever, there's a honeymoon because we're upregulating dopamine, the neurotransmitter of connection. But then the honeymoon doesn't convert to a marriage when the symptoms either don't resolve or they return. So what the Andersonis did so brilliantly is said there is a specific neural circuit for sleep. And the clenching is comorbid, absolutely, but it's a symptom. And people have been associating the symptom with the problem. And it is, but you actually clench and then you collapse your airway instead of around. So we needed the cycling time on the diagnostics to be able to get it. And that's what the Andersonis did. They actually broke it down and they didn't have a dog in this fight. They're just looking for the research. They're not trying to sell a sleep appliance. They're not trying to sell a laser. They're just like, why are people developing apnea? And it's the mesencephalic trigeminal nucleus pathway. And a dysfunctional mesencephalic trigeminal nucleus leads to sleep apnea. Because we can have, there are studies to prove this. You can have someone with a small airway.
Yep.
2 patient populations. One can breathe at night and one cannot. And it is a neural control of that. So that's why getting functional mesencephalic trigeminal nucleus pathways early in life is important. And that's why we need to avoid or appreciate the impact of early childhood trauma. Because the one thing that we know as a healthcare profession is that what one doctor will do, 2 doctors will say, listen, you should have done that differently.
Oh, yeah.
Because that's what we all can agree on, is that we don't know everything. And I appreciate being around people who are like, we don't know, but we're willing to find out. And that's what I love so much about what I do, because that's what I do every day in my practice. And I love it. But like Brene Brown said, back to Brene, one of my heroes, she said, share your truth with those who have earned the right to hear it. Because when people hear this and they're like, well, I don't want to believe it, so I'm going to make someone else wrong so I can continue to be right.
Right.
It happens all the time because if you're selling something or teaching something, you don't want anything to contradict that. And I get it. I totally get it. Because the one thing that is never going to change is that things will always change.
Yeah.
So being able to grow with the research, to be able to change your mind, which is the name of the conference, is not only the ability for people to go, oh, I can change my mind based on new evidence, but also that is what neuroplasticity is. And neuroplasticity is what we're doing with our therapies to change and improve these neural circuits so we can hopefully prevent kids from going into sleep apnea because they can't wait. And sometimes that is from the very first day of life or before.
Well, can we go back to, again, childhood traumas? They're trapped. I mean, the body doesn't know the difference between emotional pain or physical pain. Pain is pain. Matter of fact, I recently had a surgery. Um, and one of the things, I mean, they give me Tylenol. I mean, they're not, and I'm glad very limited narcotics are being given out these days, and I'm totally fine with that. They give me some Tylenol. They recommended extra strength Tylenol, a little bit of Valium. And I was like, oh, wow. And she said, all the research coming out is if you can actually, um, you know, get someone to calm down a little bit, the pain receptors, everything feels better. So sometimes just the volume alone and getting ahead of anxiety helps with pain. And then she just segued off and she goes, what's really interesting is we find a lot after surgery, people are taking just Tylenol on a regular basis for the pain of the surgery. But then they also report back to me that they're also feeling better emotionally just from the Tylenol. And she said, well, are you going through something? And she's like, I just love to dive in deep with my patients. And when you see patterns, right, Angie, we see patterns in our offices and it's like, what's that about? Just like the GLP-1s. Everybody all of a sudden on a GLP-1, they're losing weight, but now they're not drinking as much. And now they're saying, well, this could be a cure for alcoholism. All of this there's no research on that yet, but it's anecdotally, we're seeing patterns. So you have to ask the question. But she said, what is interesting is when you do take things like Tylenol for pain, the brain, even the emotional pain you're going through, tends to subside. I'm not saying this for those of you going through something hard to start taking Tylenol, but I say this because pain is pain. Trauma is not just something we experience and it goes away. If it's not, we process it, it gets stored. So back to kids going through childhood trauma that turn into big people that have trapped traumas. And then we have all these issues with neurotransmitter depletions. So what is a solution? I mean, I'm listening to this. Like, what is the answer for how do you release a childhood trauma, whether you're 7 or 77? How can is that part of your neurodevelopmental dentistry is helping with trauma release inadvertently? I know that's not your like come to me for trauma release, but as you're working through these things, are you seeing that the body is able to process a lot of things differently?
Well, and one of the things we know about science, most of the time, the research is going to prove that nature was right and has always been right. So the closer we get to the truth, the simpler the solution usually is. And when we're babies, we overcome trauma by suckling, right? Through the trigeminal circuits.
Yeah.
And then we forget about the sucking our thumb because we can't walk around with our thumb in our mouth or a bottle in our mouth or a binky. And we have to learn different ways to cope with autonomic nervous system regulation. That balance between fight and flight and rest and digest was come down to vagal tone for the parasympathetic and a lot of the trigeminal tone for the sympathetic. So as dentists, we have the ability to regulate how the body feels about the mouth. And when we make a safe place in that mouth and the tongue wants to do the tongue things and we get these functional trigeminal circuits, we do get trauma resolution. And that's one of the things that, in my career with over 3 decades at this point, I have been through it all. I've been through the purely structural, I'm only going to do what people tell me to do, follow the leader, where's the research, stay on the boat. Stay in the boat. Everyone is in the same boat. And if we keep saying the same thing, we're all going to be great. But then I put one foot off of that boat onto the dock and was like, I wonder if there's something more because I was in pain. So remember from the movie Austin Powers, the character Fat Bastard? He's like, I eat because I'm
You always
unhappy,
are the
and
best
I'm
analogy.
unhappy because I eat. Well, it's also I'm in pain because I can't sleep, and I can't sleep because I'm in
I'm in
pain.
pain. Yes.
And I became a chronic pain patient at the age of 35, went through all the things traditionally, did the orthotic, did the physical therapy, did the everything I needed to do, but I wasn't better until a physical therapist that I was working with said, "You need an ALF appliance." And I'm like, "What? Isn't that a character from TV? Like, that's what is,
Mhm.
I don't want to do that." And Kevin Ollendorf, her birthday was yesterday. We're just talking about, I asked him to make me an elf. He didn't know what he was doing. I didn't know what I was doing. But within 2 weeks, I was out of pain and I was sleeping better. And I went off of 2 antidepressants and all my pain meds. And once you see something like that, you can't unsee it. And honestly, I don't want to unsee it because then, kind of like Frank's Red Hot Sauce, I just started putting it on everything and it worked. It worked for my son who has Tourette's. It worked for my daughter who had maxillofacial trauma at the age of 10, and then had kidney stones through all of her, you know, pubertal years, which that was great fun.
Mm.
There's nothing more painful than a kidney stone, more dramatic than a teenage girl, and I had both. So you learn quickly about how to manage and understand pain. Not only from, I can have all the letters behind my name, but the most important letters are MOM,
Yeah.
MRS, and now I'm GMA. So about 7 weeks ago, I got to watch my granddaughter come into this world. And when I developed baby lays, it wasn't because I wanted to. It was because these two moms brought in two babies, and the infant feeding specialist had seen Orale's work. And she's like, "I want you to do this to these babies." I'm like, "Listen, I don't work on babies. I work on people with teeth and their clothes on. What if this were your baby?" And it was.
Yeah.
And I put my chesticles on that day and try something that hadn't been tried before, to my knowledge, which was applying through evidence-based medicine. That's what evidence-based medicine is taking things that work and learning the literature and understanding the principles and applying it to patient care in your practice, in your hands. And I did. And I got a baby that wasn't feeding to feed within 3 sessions of baby lays. I'm like, okay, can't unsee it. So Frank's Red Hot Sauce, start doing it, putting it on everything. And now I love it. But when I sat there in the labor delivery room and watched my daughter-in-law's, the fetal monitor going down and realized there was a cord wrap going on and the labor and delivery nurse wasn't catching it. I'm watching it, praying, watching it, and realizing that everything that I had been through in my life to that point was to help this little girl. So we have been for the last 6 weeks. We've been doing baby lays twice a week, doing all the physical things along with it, all the stretching, and it has kept this girl doing great. But if I wouldn't have had that, she'd probably have a torticollis and wouldn't be doing very well right now because neurologically she wasn't keeping up. She had trauma. But
Can you explain torticollis for a listener that doesn't know what that is?
so I'll use my body and my camera. The baby's body turns to one side. And that can be neurologically an issue because of cranial nerve dysfunction, or it can be from the bones of the neck, the cervical vertebrae being twisted due to a cord wrap. So when it's not treated, which is what I didn't do, I was told never to have a chiropractor touch my baby after the baby was born. And now I have that baby in the chiropractor's office, the ones who are trained to do it, not everyone.
Right,
And that's
right.
cracking necks. But most tongue dysfunction is secondary to cervical dysfunction. And I've been so blessed to have so many mentors in my life, Mariana Roccabato, Derek Nordstrom, Brendan Stack, all these amazing people. And they all agree on one thing, is that you got to look at the neck. But we as dentists aren't taught that. But thankfully, my Forrest Gump pathway of me just being in the right place at the right time and learning from amazing people helped this little girl. Another little girl, cerebral palsy patient this week. We're doing baby lays, and mom is like amazed. She's like, "This is the softest his body's felt his entire life."
Okay,
So
so let's go to baby lays a little bit, Ange, because I always refer, I mean, I'm so blessed that Angie's practice is like 15 minutes from mine. So, I mean, my go-to, I mean, I saw um three different pediatric sleep consults this week. Two of the three I really feel would benefit from Angie evaluating them, doing her neurological testing, and using the laser. Now, something, actually, all of the kids that came in, they're not related, all had releases as babies, either by an ENT or somebody. And they said it didn't really seem to help. But I said, there's a way to do it. Just, it's not just cutting a frenum. It's not just, there's a neurological component, there's a fascial component, the fascial tightening. I mean, you got to unravel all that. So and that's where I segue to you. So if we could help because we say baby lays, restore lays, oral lays. What makes baby lays different than, say, a mom, she's getting ready to have a baby soon, and she might be wondering what her options are out there. We got a new mom right now, or just anybody with, I mean, that laser therapy is amazing. My my children have had an amazing time at Angie's office in their teen years with the laser. So it can help from womb up to tomb. But can you explain what is the laser doing? You're not necessarily releasing in a way like surgically cutting with a laser, a frenum. What is baby lays doing that this mother of a cerebral palsy patient of yours is saying, this is the least rigid my child has been? Or you've got babies that are going from, they won't feed, and you didn't release the tongue not physiologically, but anatomically, you didn't release a gross anatomical attachment, but you are affecting the anatomy through fascial release, kind of melting everything, relaxing. How? What the heck? What's going on?
Two analogies that I use to help teach this is an iceberg. You can see only the smallest part of it visually. The rest of it is all under the surface. And that's what actually sunk the Titanic, not what they could see. And I think that's what's sinking so many tongue tie procedures that don't go well. So the other analogy I want to use is if you're sitting at an intersection, you have a red light, and say you're the fourth car back. The first car at the intersection, if it doesn't move when the light turns green, you still have a restriction, correct? You still can't move. So imagine in this analogy, sitting in car number one is the brain and the neurology, the neural circuits, the primitive reflexes, the feeding reflexes. Because if a baby's suck response isn't active or their gag response is too active, the tongue is affected by that. But more than that, in car number two is the fascia. The Mills research, super compelling, because what Nikki Mills as an ENT in New Zealand did is she said, why am I doing surgeries, tongue tie releases on people of all ages? Some of them work great. Some of them, there's no big change. And the other ones, the patient's doing worse. She's like, I got to figure this out. So she had the luxury of saying, I'm going to go into research for a little bit. I'm going to sidestep. I'm going to pivot. I'm going to figure it out. So she did postmortem dissections of the actual anatomy, because we all talk about anatomy, right? She did. She found out the floor of the mouth is actually fascia. And there's a lot, her research is so compelling, but no one wants to really talk about that if they don't have a tool to treat it, right?
Well, and we just had Maggie Graham on a couple of episodes ago, just saying anecdotally, and there's no research, Tracy's like, where's the research for this? Tracy's like, look, I heard it too, when you do releases and things like that, but that you have this like top down release, like almost to the point where patients feel so much like, why is my back feeling better? Why do my shoulders feel so much better since you've helped my tongue tie? Sometimes people kind of get addicted to it because it feels so good. They're like, maybe you should do a little more and do a little more. So there's such an amazing cascade domino effect feeling that comes from that. So if you could, who was the person that did the research again recently on this fascial system?
Dr. Nikki Mills.
Okay, say that again.
Dr. Nikki Mills. And all this research, if anyone wants to roll around in it, you can go to the synergy.academy reference and resources page. There's so many things on there that you probably won't find in a more traditional course that is the people around the boat. You're going to be looking at the people in the dock who are willing to explore something new, that are going to look at this stuff. So what Nikki Mills did is she realized that there was more than what is just visual, and basically said, and I like her choice of words, that the idea of a visual assessment of a tongue tie needs to be revised, because you can't see everything you can't see. So in this analogy, I'm using card number 3 as the tongue. And the tongue is not going to move unless card number 2, if fascia is moving. And the fascia is not going to move if the neurology is not telling it to move, because fascia is continuous through the body. It goes from tongue to toes. It's a web. You can't disconnect one part of the fascia from the other. So when you do a release, whether surgically or non-surgically, there will be effects at other parts of the body. The question is, how much and how long? Then card number 4 is actually the bus of the cranial vault. And the pretty little teeth are just the passengers inside going along for the ride, because that cranial vault, the shape and the function of the airway, will be created through the swallow, which is nature's resilience. That's what we do when we're stressed out, when we're babies. I'm watching my granddaughter regulate right now. And if it's not at the breast or on the bottle, it's a pacifier, which is good up until about 6 months of age. But at 6 months of age, that suck reflex is no longer reflexive. That's why it's so good to treat babies who are having swallow dysfunction in the first 6 months of life, because you have the brain telling you, listen, you're supposed to do this, so let's do it. But after that, it's gone. And that's how babies learn to regulate. So when I was talking about early childhood trauma and the cortisol, that will inhibit the projections of the prefrontal cortex and the midbrain structures to teach us how to regulate. We don't have that gift if we're not, I mean, I give it as a compliment. I'm like, to my granddaughter, I'm like, you suck. Yay.
You suck.
That sucking creates the first input mesencephalic trigeminal nucleus to be able to get that system online. And we're doing that since 4 weeks in utero. If it's going well, then the cranial vault is going to develop. The contents of the cranial vault, the teeth are going to be all able to sit in their little seats, and the airway is going to be functioning. But we have to understand this hierarchy of needs. And then the most important thing is to get card number 1 moving, so we don't have bus number 4 honking and card number 3 running into the bumper of card number 2 when we do a tongue tie release without releasing the fascia, because you're just releasing it in a pre-existing restriction, fascial and neurologically. So you're going to bounce back. Like you might get a couple inches forward temporarily, because there's a honeymoon from any surgical intervention.
Yes.
There's dopamine release, there's growth factor release. Everyone feels good for a little bit. It's a great neural hack. It's a great honeymoon. But is it a marriage? And what Orlays and baby lays are doing is looking at card number 1 and optimizing those neural circuits through getting the mitochondria and the neurons to work. So we're bidirectionally making sure that the neural circuits are functioning. We do that kind of like DSL versus dial-up. High rate of speed, we connect these circuits because it's done on purpose. That's a primary goal, neural circuit integration. And then because we're warming that tissue, we're releasing the fascial restrictions by melting away the hyaluronic acid. Once we get that temperature up to 40 degrees Celsius, the glue that is adhering our muscle to our fascia turns to goo and it starts moving. However, if you cut into the genia glossus and during the surgical procedure, when that infant or child has had a tongue tie release and the genia glossus has been altered, that hyaluronic acid glide is gone, which is why these moms are coming in and they're like, well, I did the tongue tie release and I did the lip tie release and it didn't really work because now I don't have spacing in my kid's dentition. And now they're orally aversive and we can't even put a size 0 bite wing holder in their mouth before they're gagging. But I did the tongue tie release. But they say sometimes it wasn't a complete release. And that is misunderstood so many times. It wasn't deep enough. What I look at an incomplete release as, did you address the neurological component and did you address the fascial component before you release the structural component of the tongue in card number 3? And because we're never going to get the bus to move of card number 4 with craniofacial development and airway development if those 3 things aren't being addressed. Orlays and baby lays do that intentionally with their primary goal of action is to integrate neural circuits, fascial restrictions, get the tongue working to the best that it can in the environment that it is. And then if you do need a structural release, you'll know whether it's the tongue holding it back, the brain holding it back, or the fascia holding it back, because you're doing a diagnostic therapeutic trial.
Yes.
And you're optimizing that patient. And that way, when you release them into the more optimal condition of fascia neurology being addressed, you get a more successful tongue tie release. And it's more conservative.
Well, I was
And you,
just going, that's where I was going, is sometimes, because, I have seen people, they're 45 years old and they have an obvious structural tie. They got the typical, you stick your tongue out, the tip of the tongue looks like a heart, they can't raise it very high. But you know what? They're not snoring and they sleep well and they had good arch development. And I'm like, you compensated somehow. I don't know how you did it, but you did. So, do you have situations where, so I love how you're describing this because it's like, what is the diagnosis? We say that all the time in ASAP. It's not just, oh, I see a structural tie, I see skin attached to the tip of a tongue. You got to look at function, all neurological components and things like that. Does this warrant intervention? Because you got people out there just slicing every frenum, giving it a bad name, and no one's advocating that ever, even though it does sometimes happen. Do you go through your process? You're looking at neurological components. You're doing your testing, and then you're looking at, you do your baby lays or your orlays, and you're getting that hyaluronic acid melting, gliding, and even though they have the structural tie, have you just said, you know what, we're actually good and we don't need to do the structural tie? Are there ever cases where you might have that happen?
yes, because it's that patient's choice. I will tell them, listen, these are your options. You can do the structural release at this point because it's optimized, and that's what I recommend so you don't have to compensate further. But also, it is your body, your choice. If you've read up on the dangers of structural tongue tie release and you know your body's going to change and you don't want to, it's on you. It's my job to educate, not make people forced into a decision that they're not comfortable with. But I literally, if someone comes in my office and says, I just want a frenectomy right now, I'm like, you obviously don't know me very well. This is not going to happen today. Like, you can go right down the street and they'll be happy to do that. But I'm going to do a careful assessment and restriction elimination, which is what we call the care release. So careful assessment, restriction, elimination in the right order to make sure treatment sequencing is successful. And that way I don't have to look back with regret and know that I changed that person's vector for their entire life in a way that is not as optimal as it could have been. I want it to be forever and I want it to be good. So, and once you've been around for 30 years and you start seeing your patients bring in their children and then their grandchildren,
Yes.
as a general dentist, they're part of my family. They're
Hmm.
in here. They're not just a procedure to me. So it's important to me to be able to bring this forward because I I absolutely love what I do and love the miracles that I hear every day. And when someone says, "Where's your research?" I mean, I was trying to tell Stacy, trying to read to her a testimonial last weekend. All of a sudden, I'm like, I can't read it. I'm crying. She's like, but that's what people want to see. I'm like, no one wants to see me cry. I'm not a pretty crier. But when you change the lives of these patients like this and you give them their children back through one procedure or having an alpha in the mouth for 16 hours and their kid is different because you did it right. You got the treatment sequencing right. Car number one, car number two, car number three, patients on board, they're invested, they're doing their thing. It's magical. And that's the miracle of nature. And that's all we're doing is we're understanding what the body needed. We're giving it to them. That's why I
Angie,
love what we do. Even though there might not be research to support it, my
I'm glad
research is in my
you're,
practice
you're
every day.
you're bringing that up because I'm here at the ADA, and one of the things that we're talking about is what's the evidence, right? So, what's the evidence for expansion? What's the evidence for having children be managed orthodontically and orthopedically earlier than what the conventional guideline in our industry, which is the first orthodontic evaluation by 7. That's our traditional guideline. So when we're talking about all of these Orlace, Baby Lace, ALF, and people are saying, well, there's no evidence, there's no evidence. Uh, you've alluded to it already, where if our patients, as a provider, we're seeing there's something missing, and that's the boat that I was in, right? I know that there's something missing. I know that I wanted to make a little bit more of a difference. I wanted to be able to give some insight and education to my patients. So for those that are in the boat that I was in, in the boat that you were in before too, right? And they're uncomfortable because we're being told there is no evidence. What should we consider? What should we think about?
This is such a good question. I wish I had a perfect answer, but what I do know is that the evidence that you're now basing your decisions on is going to change because the research is going to come out and disprove whatever you thought was right in that moment. Second of all, there is no control group for human development. One of the things I love about Gabor Mate is he talks about a biosocial psychodevelopmental model, which means we as humans cannot be separated from our environment, and we as structural human beings cannot be separated from our brain. And if you're not taking that into effect when you're doing your research, the etiology of what's actually going on, you're missing the boat. Intermolar distance, that's cute. Like I want that person to feel well. And when we are doing our assessments, to be able to use the trigeminal nerves through the mesencephalic trigeminal nucleus to the locus coeruleus, which is basically the Libra of the brainstem. It's a balancing act. So basically the locus coeruleus is a brainstem nuclei that says if there's an imbalance in the trigeminal, it's kind of like having a table wobble at a restaurant. Someone's going to try to shin that up because that's unsettling. What the body will do is compensate. One shoulder will go up, one hip will go down, everything goes out of whack. And when we can actually measure that in real time through the vestibulospinal pathways, we do research every day on our patients, but it's basically every day that can be different. Sometimes their moral reflex is going to be integrated and sometimes not. Sometimes their swallow is going to be supporting them neurologically and sometimes not, because this is what the research shows, that the OMT habituation exercises are actually to put the tongue on the roof of the mouth is actually stressing people out and causing more craniofacial pain. And that research has been repeated. But where do we hear about that research? Only from people like me who only want to share their truth with those who have earned the right to hear it. Because this is scary. This is vulnerable to go out and get off that boat. Because the people who are on the boat will want to push you in the water.
Yeah.
Because no, everyone stay on the boat. And I've got off that boat. And I remember Brendan Stack telling me, you're always going to know the leaders by the arrows they have in their back. And that's what
Yes.
Stacy alluded to earlier. This is not easy. But I do it for my patients, and I do it for my granddaughter, and I do it for my son. I don't do it for the glory of publishing a paper. I do it because there's a difference between a doctor and a healer, and I want to be a healer. And I'm not going against anything that anyone's saying. I'm not saying the research is completely wrong. I'm saying it's not completely right because you're not looking at etiology and you're not looking at the variables that I'm looking at, which is neurology. And I've reached out to people to do research, and we're like, let's develop a project. And they're like, these are too many variables. Like, and if anyone says, here's your research, I'm like, show me your research and I'll tell you what is wrong with it. Because the clinical equipoise means there's genuine uncertainty in any human research. So I completely understand when people want to feel safe on their boat. And if that's what they want to do, stay on the boat. But if you're like, there's more. Yeah, that's what medicine is. We're never going to progress as a profession if we continue to just stay on our boat and do the same things.
Right. And we
So
had
there's,
Alan Reisinger on a while back, and he said, and just in the science of science, basically, it was like the research of science is 50% in 10 years, 50% of everything you're learning in dental school and med school will be considered wrong. We just don't know it 50% yet. So, it's always changing. Like, can we all just set ego aside and know that, look, I graduated dental school 20 years ago. I mean, I don't practice anywhere near like I used to practice, and I'm glad. And in a few years, I won't practice the way I'm practicing now. And I think patients have to understand that too. I think is, you walk in and you want all the answers right now, and it doesn't make your doctor a bad doctor if they don't have all the answers. I mean, this is a very dynamic, changing science, all of it is. And pediatric airway, sleep medicine is a newer science. Of all the sciences, sleep medicine's newer, and pediatric sleep medicine, geez, I mean, we're all in the trenches. We want the answers that we're going to have in 10 years right now, and that's a bit frustrating for everyone. But we just are also, for such a time as this, right? For such a time as this, we are here in the moment that we were meant to be part of the development of what the answers will be in 10 years
And that's
for
why I measure every single
grandkids.
patient at every appointment. I'm doing my research on them. I'm measuring their neurology through their body. Their body will tell me what they need based on movement patterns.
And I
And it
think
could be
too, like that's your point with neurodevelopmental dentistry. All of dentistry, everything we do, every crown, every filling, everything we do affects our neurology on some level.
everything.
And what you're saying is, look, you do you. You've got your classes under your belt. You have your techniques that are working in your practice. You all have your success stories. Dentists, dental sleep medicine docs, we all have our success stories, but we also have the person that, like, wait, I had someone built just like you with the same AHI as you, and I put in a prosomnus and they totally normalized and they felt amazing, and you don't. Why? What could I be missing? In a child, you've done the expansion, you've maybe done some myofunctional therapy, you've seen some improvements, but now what? And I love, Angie has said this before, like ALF therapy is its own training. You've got your own training behind ALF therapy and the side effect of ALF is getting the tongue up and you start to see expansion from the tongue being in the right place. It's not necessarily that ALF is the expander, but its side effect is expansion at times, but it's more of a neurological connecting the tongue to the roof of the mouth, getting things working and connected. But sometimes too, like, hey, you've done your expansion. Maybe you can look at the neural side and maybe use ALF in that retainer component. Okay, you got the best retainer and the best orthodontist on the planet is the tongue, and the best retainer is the tongue. And also the worst orthodontist on the planet is the tongue. And so it's getting that tongue under control, doing what it was supposed to do, So yeah, you've done your expansion. Now what? Maybe you could look into ALF therapy as more of a neuro retainer, getting things back online. And I think there's ways we all can work together in this. And I know I'm going to put the synergy.academy. Is that where your research is?
Mm-hmm.
And then
Well,
I will,
the literature references that support what we do as evidence-based providers.
thank you. Thank you. Not your particular research, but the research you reference
Yeah,
for the
because if I
therapy
wanted to
you
be a
provide.
researcher, I would have gone to school to be a researcher.
I know when
I
I
don't
said that,
want
I'm
to
like,
do
it's not really
research.
your research, but your research, that the research you reference that supports your therapy is under synergy.academy. I'll put that. But you also have a website where people can take courses if you're a provider and you would like to learn more about how to maybe collaboratively add this in as your now what. You've done everything else. Maybe this is something you could be missing, or, learning how to test your patients neurologically before you even start. Angie, you and I have had this discussion. It's not like you're saying traditional expansion is wrong or bad or shouldn't be done. It's just you have an alternative way that you do it. But there are some kids that putting an RPE in or putting in a Schwartz or Marpy might throw them over the edge. And how do we know which kids those kids are that might need a little different technique to accomplish the goal? That's your point with neurological testing up front to see, hey, this kid's full engine's running. I mean, go ahead, expand. This kiddo over here is barely putzing away. And if you put something in their mouth, you're going to throw them over the edge and they might actually get worse. Even though you accomplish anatomically what you wanted to, they're not neurologically ready for something like that. Did I explain that correctly? Like how you could do an upfront neurological assessment? That's something you teach as well.
Yes. So we teach that assessment. We call it the switch test, which is strength with integration of trigeminal and cranial harmony. So the switch test is a super easy thing to do. We also have the stop assessment, which is the subjective test of pain, because if you're doing a palpation exam and that you notice that the floor of the mouth is tender, that's a compensation for a dysfunctional swallow, therefore a dysfunctional trigeminal neural circuit, therefore pain. And you're not supposed to have pain in your mouth when you touch anything. So we're looking at the compensation patterns for the dysfunctional swallow. We're addressing them as the first part of valve therapy. And if we can't do it with just valve therapy alone, that's why Derek Nordstrom invented oral A's, to be able to go to get the tongue working, because it's not an ALF if you're mechanically moving the teeth through the bone. That's bastardized ALF. That's fake ALF. That's not what ALF is supposed to be. ALF is organic growth, with the appliance being a vector of that growth, but the tongue is what is doing the growth. Make no mistake that this has been misunderstood, and that's what people say, oh, ALF won't work. Well, it won't, A, in the wrong hands, and B, in the wrong patient, because if you don't get that swallow going, you're not going to get organic expansion. So, or if you do it too quickly. So we're waiting until we get our patients neurologically regulated before we go into active expansion, because we're putting the cart before the horse if we don't. Because car number one has to be moving, and the body has to feel safe. We're looking for autonomic nervous system regulation, which is why we have patients come to us when we put the ALF in the mouth and they start sleeping better, breathing better from day one. We didn't need to do the structural expansion. We didn't need to do the tongue tie release. We've had patients who have had beautiful Invisalign expansion, vertical, transverse, all great. They're still sleeping with their mouth open. You put the ALF in, the lips close, and they do great. There's others that happens on day one, and others that it might take a little bit longer, because there is no control group for human development. Some of the boo-boos go back way longer than just, the age of 4, when they bumped their head and then their tongue went low to help regulate their vagal tone. And then they didn't swallow good anymore, swallow well anymore. That's the hardest part, is that people want easy answers for
Yeah.
really, really complex things. And I really only want to have these kind of conversations with people like you who get it. It's not that simple.
Oh,
We're,
Lord,
we're,
no, it
we
is
are
not.
complex human beings. That's why I love when Dania Tamimi got up on stage at the Academy of Craniofacial Pain Symposium a few years ago, almost a decade now. She literally kicked off her shoes and says, if you think you can measure an airway, a dynamic airway with a static image, you're out of your mind.
Yep.
Also, look at all the asymmetric expansion that they're catching on the beam readers reports from RPE and other things, that, because, the law of motion is that whatever is not in motion is going to continue to not be in motion. Whatever is will continue to be, right? Well, typically one temporal bone in the cranial model is more rigid and the other one is more mobile. So we get asymmetric expansion in patients like that. Wouldn't you like to know that before you did that? Wouldn't
Yeah,
you
we're
like to get
seeing a
that
lot of
going moving?
asymmetric expansion. And then Audrey Yoon, God love her. This is what I love about Audrey Yoon. Um, she had a whole ASAP meeting with us one time, just even about, and Michelle's shaking her head, yes. I
Oh
mean,
yeah.
it
Yeah.
was all, and what's interesting, she got together with other providers of MARPI, and Audrey's doing some amazing research, but she said, I just want to show you all my mistakes. I just want to show you, I want to show you when it doesn't go exactly the way I planned it to. And now what I'm learning, but you don't know what you don't know. And then you get in there and it's the practice of medicine, right? We all start figuring things out. I'm going to have the links to all of this information. Angie, I'll get that behind the scenes from you. I know you have to make some tweaks to the website, and I'll get that put in. Um, we'll probably have a part 3 because we probably need to. And I know got to wrap things up today. I want to say thank you for stepping out of the boat and saying, I'm going to honor what feels good to me for my patients. And you can't unsee what you've already seen. So thank you for doing that. And I know, because look, Angie and I have a lot in common, but where we do not have things in common is I love to talk. I love to, kind of put things out there. And Angie's like, I'm in my practice helping people. I don't want a bullhorn. I don't need a megaphone. I don't, so for her, I'm like, come on, get on the podcast. Let's talk. But she does this because it's not that she's promoting what she knows is missing. And so I know that this is not your like favorite thing to do. And but you know it's necessary, and your heart is huge, and your love for people, your love for your family, your love for your patients and your community is just oozes out of you. You're such an authentic, genuine person. So thank you for being here today. And you did not read the testimony, and you did get upset at the table when you started to try to read it. But so maybe Evan and Emery were two testimonials that you had that one was written by a parent, I think, and one was written by the patient themselves. But maybe you could just summarize before we go today
Okay.
what these patients wanted to share with you. And I love one of them in particular, or maybe both, but you didn't even mention anything that could possibly happen to the parents. So the realizations and the experiences that they had, this isn't a placebo where you possibly planted this as an outcome. They had no idea these were even possible.
Well, I always say that in any therapy, and especially with alpha orlays and baby lays, we create the possibility, which then hopefully, if everything goes right, it's a probability, but it's still a possibility. We can't make any promises. So this particular story I'm going to tell you, and we could talk all day about all the amazing ones, but this one is most recent. That I have the two moms that adopted kids from an orphanage in South America. One mom has three kids. She has one biological and two adopted. The other mom has one adopted that I'm treating. And they all drive, several hours to get to me because they were told they should get a tongue tie assessment. And Emery had condylar hypoplasia on one side, massive asymmetries, all kinds of really difficult orthodontic things, but also pretty significant ADHD. Within getting the alpha in her mouth, within a couple of weeks, she was totally regulated to the point where mom was like, people don't even understand what is the big change in her. And we hadn't even moved any teeth yet. And now she's in the process of doing that, and we're doing great. And she's growing, and she's surviving through things that I'm sure happened to her very early in life, which Gabor Mate talks about, through her whole body offline with asymmetries and not having the craniofacial or neurological development. And she's thriving, and she's entering beauty contests, and she's so articulate and beautiful. And then younger sister we started recently, and she's also sleeping better and doing better in school. But their biological son, they're like, well, let's just go ahead and, get him treated too, since we're coming here for the other girls. She didn't tell me anything about his history, that he used to be, this outgoing, excited, loving, energetic boy. And in the last year, that all stopped. And he started just being sullen and no energy and tired all the time and crabby. And he had a little bit of a deep eye, a little bit of a transverse discrepancy, not anything huge. Reflexively, he wasn't horrible, but he also wasn't good. I would never have anticipated this, but we did the proper design, proper implementation of the alpha appliances for him. And mom sent me this letter 2 days after insertion saying that they have their son back, that he got out of bed. He's like, let's go on a hike. So they're like, okay, who are you? And what did you do with Evan? So they followed him on this hike, and he's laughing and he's singing and he's telling stories and he's doing all these things that they hadn't seen for a year. And then they came back home. He's like, now let's go swimming. And they're like, oh my God, we're so tired. Who are you? They got their child back. And I would never have predicted that. But that's the kind of things I see every day that gets me addicted to the miracles. The other family has a little girl that was below norms on her growth. They've tried growth factor. They've tried everything. She was in a herpes, and she was in full expansion when I saw her, and she was not doing well. Nonverbal, she could walk, but not well. She couldn't play outside with her siblings. And within 2 weeks of having the Alphin, she kept playing football with her siblings, and we could understand what she was saying. She was speaking and we could hear it. And she was balanced, and the growth therapy was working. They're giving her growth hormones. She's grown 3.5 inches in the last 9 months of treatment and put on almost 10 pounds, which the doctors are just amazed. Her neurologist is this is a miracle. And I didn't move a tooth. It's a retainer for her because she was actually overexpanded, but her head was locked up and reflexively she was offline. The orthodontic therapy could have potentially made her worse instead of better. And that's what their observation was. So when you have stories like this, you can't get back on the boat. I can't go back on the boat. I'm happy to be here, happy to bring other people out of it with me because this is how I change lives. I feel like this is my contribution to our human race. I'm
Oh,
just really grateful the opportunity to do it because like you said, I'm the one that's just going to stay in my little shell and
she
keep to
does,
myself.
but I pull her out once in a while to come talk.
And I'm so happy you do that because I would never have found Angie and what she does. And here I would be continually looking for things that I just don't understand. And I just know there's more and I just didn't know what else to do. So I feel like this is a what's next. This is
It
kind of like
is.
once you've done and you've understood how to modify anatomy, how to help patients with oral appliances and everything else that we know to do in dentistry, when you see those patients that are still in need, you see a different dimension and you're just like, and what you're saying, Angie, it's addictive, right? It's addictive because you see the good it does, not just for the patient, but for the whole family.
And generationally, because when you
Yeah.
change a brain and you improve neural circuits, you're epigenetically changing the downstream for that for many, many, many years. So
We haven't
that's
even
why I love
talked
it.
about that. That's why
Oh,
there's
Mo,
gonna be
I feel
part
a part three
three.
coming on epigenetics of neurodevelopmental dentistry.
Yes, 100%.
No, but it's so true. And Michelle, you're so amazing with TMJ discussions, TMJ dysfunction, and again, when you look at the structure, and we are as dentists, or even in any healthcare profession, chiropractic, physical therapy, occupational therapy, speech therapy, anybody that's in any kind of therapy, you're looking at the hiccup anatomically or physiologically, and we want to just put it back together. But it's really being a good investigator and a listener and diving into why that hiccup happened in the first place. And sometimes we may not ever find out why the hiccup happened. I mean, I had a parent asking me last week, why did my child start mouth breathing? We don't understand. Like, it's like the chicken or the egg, and it's like we don't 100% know. They could have had, an infection and they were not nasal breathing as a baby or a 2-year old or a 3-year old, and then they got disuse and just never got back online. We could sit there and try to figure out exactly, and we probably aren't, but it's looking beyond the anatomy. The anatomy does tell us a story, but so do the reflexes, so does the neurology, and it's learning to go beyond the anatomy and listen to the body. It's trying to tell us something, and we have to be open to learning this other way as healers, as physicians, as dentists, of listening to our patients, what they're saying, but also what their body is saying to us that they can't articulate and don't even understand fully. So I'm going to wrap it up here. I definitely wanted to go into, we always have our courses. So we have the immersion course for those that want to do the ASAP immersion. And that is open right now. Part 2 is closed, but you can jump in for part 3 immersion, and registration closes September 29th. But this is like learning ASAP, pediatric dental sleep medicine, radiology. We have so much to dive in, and we discuss once a month from September to December of how you can learn more, implement this, and it's kind of like our Sunday chats. Then we also have early ortho intervention. You can actually purchase the part 1. There's a recording for the part 1 if you want to understand that, and then dive into live part 2 with us. And then we also have the skeletal expansion part 2, which is really more of an aligner, how to finish if you've done skeletal expansion and TADS, how you work with this with aligner therapy and how to finish off the case that you expanded. We also have Dr. Tran. She's teaching a frenectomy course as well. And Dr. Tenholder, Angie, she has, if you're an ASAP member, we also have her as faculty. We're just so honored to have her. And I'm going to pull her and connect. I'm going to connect her with people that I want to better understand what Angie's doing so it can be more comprehensive. So we're doing a lot behind the scenes to get this kind of care, this quality healthcare into more doctors' hands to help more people.
Can I
And
add something
yeah,
to the course list that you gave? Because so the immersion course, the registration ends September 29th, but
yeah,
actually the course starts September 1st. So if they can have access before September 29th, obviously, if they can have access on September 1st, they will
yes,
have a whole month to go
yes,
through module one, because at the end of September, we're going to go over module one and talk about whatever questions they have or any difficulties they have in implementing. So if, I know that the registration ends end of September, but it would be really good if they're interested in doing it and joining that
for
third group of it.
September.
Yeah, if they can do it before September, so they can September 1st really
You're jumping
start.
in with us because there's a lot to learn, everybody, but it's great because you can learn in your pajamas, listen in the car, different things like that. I like
And
online
then
learning.
yeah, and then for the skeletal expander, this is completely new. This course
Part
that we
two.
have, that's part two, because so many people are now are able to expand and they understand the mechanics of the skeletal expansion. But the difficulty, I think, is once you have that diastema open and once you have that skeleton expanded, how do you set up the Invisalign? So actually, it might be even better for people who are interested in doing this to take this course first.
Right. This could be your part one, the part two,
Right.
because you have the end in mind
You have
before
an
you even
exercise,
expand. Yeah.
which means your diagnosis, what you're looking for, all of those things will be a little bit more honed in. You'll already have a plan. And then, you plop down your knowledge of doing the skeletal expansion. And even actually, there are some people that have no intentions of doing the skeletal expansion part, right? So they will outsource that and refer that to their favorite specialist who is doing that. And then, they'll do the management of the orthodontics in their office. So this might be a really, really good part for them to jump in and start learning this whole procedure and this whole process so that it can be incorporated into their practice.
Well, we just had this discussion with Lena because, I mean, she comes from a restorative background, um, and then went into learning more airway health, sleep, expansion. And she said, you really need to either know a good restorative dentist or be the good restorative dentist that has the end in mind, that understands where are we going? Because you can overexpand. And where do those teeth belong in the bone? And so you really have to have the restorative end in mind first. So, like to your point, this part two with Dr. Ilya Lipkin could be your part one. And then you can circle back and take the part one expansion aspect. Thanks for saying that. That's a
Yeah.
valid, very
Yes,
valid point.
it's not like first and second part, and you have to take it
Yeah.
in order. There's really value in both, and it's independent of each other.
And if
And
you
then
want to take the part two early ortho with Dr. Courtney Levine and you didn't take part one, because that does build, you can get the recording.
yes, and I forgot to mention that, but thank you for reminding me. This is the last course on schedule for Dr. Courtney Levine
That's right.
because she has other things and other commitments that she needs. She just had another baby. I don't
She
know whether you
did.
know.
She did.
So
So she's this if you want this is your opportunity. And I believe the prices go up August 1st on a couple of those courses. So that's next week. So actually this won't air until after that. So sorry if you missed the sorry if you missed the hopefully you jumped in there. Okay, I'm going to ask my three random questions here because we've got to wrap up. So here we go. Angie. Actually, I might ask you for, you might be the first person in history that I asked for because I just wanted to know this. One, are you sweet or savory?
Oh, I'm both. I think more savory.
I knew it. I'm thinking, I think she leans more savory just because of what we eat together. What about you, Michelle?
I was sweet, but now I'm getting going savory.
That's because we're getting older. Our taste buds are changing. I don't know what's going on. I'm
Oh,
more
it's
savory too. And I mean, I won't turn down Reese's peanut butter cup or
Me either.
ice cream but I will I prefer savory. Oh, yeah. Okay. Favorite thing to do on your day off, Angie?
Chill, garden, relax,
Mm,
not think,
your
sleep
garden.
in. I
Yeah,
love
sleep
sleep.
in. What a treat. Like that hardly happens, right?
Mhm.
You have a beautiful garden, by the way. That's why partially Angie's house is like a retreat, no joke. So when my projects are all done, I'm having you guys over and then we can sit on my patio. Please let this patio get done, but I'll have you over someday. But for now, I like to go to Angie's. What about you, Michelle? What do you like to do on your day off?
Dance.
You do. You're a dancing fool. That girl. You're so talented. I kind of like to do the same thing as Angie. Just if I can ever sleep in, what a treat, like it's rare. So I do like to do it. I love to have coffee in bed and kind of get caught up on stuff, even though that's still kind of working. And then, yeah, I just like to. I joined a new gym. I love my new gym. It has a sauna in it. So I've been doing a lot of sauna, which has been good for me. So I just need more days off. Okay, Angie, if your career was a sport or a game, what would it be?
Gosh, chess,
Ooh,
because it's very analytical and I have to understand my move before I make the move and
yeah,
then look to be 3 steps ahead.
I like it. That's a great answer. How would you describe your career right now if it was a game or a sport, Michelle?
Um, I think I'm gonna go back to dance.
Oh,
Because
yeah. That's great analogy.
there's so many
Ebb and
different.
flow, go with.
Yeah, the choreography of everything, the flow of everything. So each office has their own flow, and we're choreographing things, people moving in and out of, the patient, like just a patient appointment. To get through a patient appointment, we're moving in and out. It's my assistants and my hygienist, and it's me. Yeah. So yeah, it's a choreography, it's a dance.
That's great. Some days I would say mine's like whack-a-mole, but then I also think because I'm trying to learn pickleball. Oh my gosh. Um, so I feel like I'm learning. I feel like if I could define, I'm still always learning. So, I mean, it's a new sport for me. Some weeks I show up, I'm like, oh, this is so old hat. This is like, I can do this in my sleep. And then other Mondays I show up and I'm like, what is happening? I'm having to relearn so much this week. And, the universe is putting me in a very humble position this week of student. So yeah, it's like learning a new game for me right now, which is pickleball. Okay, last question. This is a fourth, so I only do this because I love you, Angie. Okay. Um, have you ever had a life-changing revelation? And if so, I mean, I know you've had several,
But
but
like, how long do we have? I've
I
had
know.
so
Well,
many.
I know I'm like this, Angie. I got to ask. So, what was a recent life-changing revelation for you?
I think being a grandma. And
Hmm.
instead of just having it be patients who are coming in that I'm supposed to help and then send them home, to be able to watch this beautiful little human being grow and be able to give her the things that I've had to learn, not because I wanted to, but because I think God put me on this path for a reason. And all of a sudden she's here. And I'm like, okay, I do just like being a grandma for a moment and just enjoying the baby. But then I'm like, we have some work to do, little girl. And that's, I think, probably my biggest revelation is it just how important it is to be able to do what you guys already believe is your motto, which is because kids can't wait. She couldn't wait for me to show up and be Dr. Tenholder 2 weeks after she was born. She needed it in that moment. So that's probably my
I
biggest
love
revelation.
it. It's
Amazing.
perfect. Yeah.
That's so amazing. Isn't it funny how the universe works like that?
It
Hmm.
is. Michelle, do you have any life revelations?
Here I am thinking what it could be. So I'm here at the ADA, and you know that I brought my kids with me, and they're helping me out at the ASAP booth. And it's funny because a lot of people are coming up, and as it is in this field, many of the people who entered it have their own families in mind.
Yeah.
And many of the people that are here are starting out their journey, and it's kind of amazing to see. And they're talking about their child, and so it happens to be that I was in the booth standing beside Matthew. Somebody was talking to me and saying, I really want to do this for my child. And, what would you recommend? And what would you do? And I looked at Matthew and I looked at her and I'm like, that's the reason I'm here. He's the reason I'm here. And she's, her child was like 4 or 5 and Matthew's 18. So that is a life-changing event for me,
It
right?
is. And like this weekend, it kind of came full circle, right? Like you're
100%.
seeing like here you are at the ADA Pediatric Airway Symposium with your
With your
son,
kid.
who
Yeah.
you've been doing all of this for. Oh gosh, now I'm gonna get emotional and I did not anticipate this. Dang it.
Started it. You
It's
got to
just
finish it.
every
Oh
time
my
I
gosh.
talk to Stacy and now Angie, I cry.
Well, it's because gosh, it's so funny. And I'll be transparent. I was seeing you. Oh, I can't say this. Okay. I was seeing your pictures on the plane with the kids. And I think nothing has humbled me more this year than my relationship with my kids. Um, just are growing and getting older. And, I have 1 year left with my son at home. And my other two are just navigating their life. One graduated college, the other one's going to be a sophomore. And I've got this precious year left with my baby, Judah. And I was watching your pictures on the way to the ADA for ASAP. And I'm like, I'm so grateful to your kids that they would want to be there to help ASAP. All our kids here, Angie can, attest to this. We work really hard in our practices helping patients, but we really also did this for our kids selfishly, right? And now we want to take this and help our patients with it too. Because once we helped our kids, we're like, every child that walks in now becomes ours too, on some responsibility level, right? So I was just appreciative of for Katie and Matthew going. I'm like, what great kids you and Rich have raised. And then I was thinking how lucky you are that your kids want to be around you right now because I'm going through some stuff. But I think one of my revelations, just even this morning, I was driving around, drinking my coffee, watching the sun come up. I just love to do that, even though it's a Saturday. And I was listening to Wayne Dyer at talk, and he said, you look at a seed and you don't see its treeness when you look at a seed. You don't see its treeness at all, but it's going to be a tree. You know it's going to be a tree. What's the evidence that it's going to be a tree? I don't know, but I know it has treeness. It's going to be a tree. And just having faith in your life. And, the thing he also said, which is so to me relevant to what we're talking about today, especially in utero discussions that we're having. And he said, a baby, the first 9 months of life, it's not in there worried about, looking at a sonogram. Oh, I sure hope I grow a nose. What's going to happen? Oh my gosh, I don't have a nose yet, and it just does. It just is. And this life force, it just is. And then we get out and it keeps going. It's not like this life force feeding us stops. It keeps going. And we have to have that faith that we are where we are. And sometimes people like us tend to do, fix, fix, fix. And then the message was, it's already being done. Settle where you're at right now and know that nothing that's happened wasn't supposed to happen. It happened. You can't experience joy without sorrow. You can't experience satisfaction in your job and success without failure. And just know you're being done. You don't have to do. Just keep going. And we all have our treeness, and we just have to have faith that it's going to unfold as it's supposed to. So, on that note, this was an
And I have
emotional.
one thing to bring it full circle, and I show this at every presentation that I do, and it's one simple slide. It has two simple little thought bubbles. And the first one says, I love you. And the second one says, do you have evidence to support your statement?
Yeah,
That's
love.
kind of where we all are.
It
We
is.
love our patients. I love you guys. Thank you for having me on here.
Love
Thank you
you
for
too.
what you do. And thank you to everyone listening for what you do to help your patients as well. So thank you very much.
And you can't end any better than that. Goodbye, everybody. See you next
Bye.
time. This podcast would not be possible without the inspiration of my dad, Dan Becker, and creative direction and editing from the talented Jason Becker, Benjamin, and Judah Walker. To stay connected and keep the conversation going, be sure to subscribe to our podcast and visit our website at asappathway.com. And remember, the information in this podcast is for educational purposes only. It's not intended to be used as medical advice to replace your healthcare provider's diagnosis or recommendations.